Thank you, Chairperson. Good afternoon. So my job is to tell you about the identification of a worsening heart failure, and probably will get some time to tell you the recent breakthroughs. This is a very important concept nowadays because one of the commonest cause of admission in most of the hospital is heart failure. Just to tell you this important slide, this is a very recent publication, although the data from USA. Over last few decades, you can see in this chart that after 2011, the mortality due to heart failure is rising. Despite good advancement for foundational or fifth foundational therapies, the mortality is not going down, it is up. We'll discuss why it is so. So coming back to the topic. So once we diagnose a case of a worsening heart failure, what are the important concepts? There has to be the worsening in the signs and symptoms of the heart failure because that is a sine qua non. It has to be a case of established congestive heart failure, and there has to be a strong medically recommended therapies in a proper doses. And that should also include not only the hospitalization but escalation of the therapy. So these four components, if they are present, we call it a worsening heart failure. And every year we see some refashioning of this statement because of the fewer molecules which are coming to the horizon. It is also a known fact that if there is this conglomeration of the finding, once we are labeling a patient to be in hospital or upgradation of the diuretic therapy, the prognosis is going bad and bad. So what we call, once you are worsened, it begets another worsening, and naturally mortality is going to be much, much more. So what is the outpatient worsening? This is important target because we see daily patients and none of the heart failures are really stable. Either they are controlled or they are uncontrolled. So just like in oncology, either they are in remission or they have an active malignancy. So similar concept to the cardiologist. So if we have to escalate the therapy, particularly the intravenous diuretics, and nowadays it is to the oral diuretics, this is one of the important concept in worsening heart failure. Because if you land up in hospital, there is no doubt it is a worsening heart failure. So the consensus statement, this is from the European, it includes and what it doesn't include. What is important, exclusion is new onset of heart failure is not a worsening heart failure. So first time you have encountered a patient with a systemic or pulmonary congestion with a structural or functional abnormality in the heart, this is not a worsening heart failure. So you have to exclude that. So in a well-defined cases of heart failure, we are silent. I am not saying whether this is reduced or preserved. So established heart failure on a therapy, if there is a worsening, this is worsening heart failure. Although we do not have much data about preserved EF, most of the data and the treatment is for reduced ejection fraction heart failure. The site of care is also not that important because initially it was only the hospitalization, and nowadays it is evolving from IV furosemide or IV other diuretics to oral escalation of diuretic will also be a congestive heart failure. So this concept is important because the mortality keeps on increasing once you have a number of factors if they are increasing from 1 year 10-12% mortality to 40% mortality if you have say 2 or 3 hospitalization within a year. So getting to the hospital was subjective because it depends in which part of the world you are practicing, in the rural setting, metros, in the corporate hospital. So this hospitalization is very subjective. So you have to take also that into account, whether you are reimbursed or you are on a salaried basis. There are so many things for getting a patient in hospital. So hospitalization decisions are mostly subjective unless the patient is in a really bad shape. So despite these understanding, we have to know how we can prevent it. And if you can't prevent the worsening, if you get such patients, you have to tailor your therapy of the heart failure in such fashion. Now, intensification of diuretic, this is very important concept. I keep on saying patients on 4 pillars of therapy without any diuretics. That is one of the most important cause of worsening of heart failure. So the assessment of a systemic congestion, assessment of pulmonary congestion is really important. And we are seeing 40, 50 patients, not 6 to 7 patients as our Western counterpart. So probably we need some sort of a help on that front. So if you do a proper assessment, need of the diuretics will be there. So if they are not on board, you really can't label them as a worsening heart failure. And how do we treat case of heart failure with diuretic? I'll recommend one of the good publication is Enact Heart Failure. This is for the internist. If you see the protocol, how do you double the dose, whether you give a continuous infusion or a bolus, there is a way. Do you measure urinary sodium to see the effectiveness of your diuretic therapies? There is a way to do. So Enact Heart Failure is one of the important protocol, at least for the internal medicine or even cardiologists. So we have learned about the 4 foundational therapy over last 4 years, and it has been shown that if most of the patients are on at least 50% of the doses of a 4 foundational therapy, you get the better outcome. Do we get much more importance if you are unable to reach 100% of the target dose? There is a question mark, but we'll come to the strong heart failure data. I always say try to achieve the maximum target dose. If not possible, try to reach at least 50% of the target dose of 4 foundational therapy. Probably will get similar result. So worsening heart failure represents an highest unmet need, because if you look at the trial, whether this is a paradigm or DAPA heart failure, or for that matter Victoria, the placebo control arm has got very high event rates. So look at the DAPA heart failure. Event rate in the placebo arm was, I think, 14%.